Hello everybody. Today we are going to discuss about the carbon monoxide poisoning. Carbon monoxide poisoning is common, resulting in more than 50,000 emergency department visits per year in United States. Sources of the carbon monoxide include faulty funerals, faulty furnace, faulty furnaces, inadequate ventilation of heating source, and exposure to the engine exhaust. Now, pathophysiology of carbon monoxide poisoning. Carbon monoxide diffuses quickly into the blood by way of the lungs and causes injury and adaptive response that continue after carboxyhemoglobin level have returned to the norm. So, carbon monoxide causes hypoxemia through the formation of carboxyhemoglobin and the leftward shift of the oxyhemoglobin dissociative curve. Carbon monoxide binds to the heme protein such as cytochrome C oxidase, impairing mitochondrial function and thereby contributing to hypoxia. Brain hypoxemia elevates the level of excitatory amino acid, increasing brain nitrite level and causing subsequent injury. Brain hypoxia causes the oxidative stress, necrosis, and apoptosis, contributing to the inflammation and the injury. Carbon monoxide also causes the inflammation by increasing level of cytosolic heme and heme oxygenase 1 protein, resulting in intracellular oxidative stress. Carbon monoxide bind to the platelet heme protein, causing release of nitric oxide. Excess nitric oxide produces peroxynitrite, impairing mitochondrial function, which contribute to hypoxia. Carbon monoxide causes the platelet to neutrophil aggregation and neutrophil degranulation, involving the release and the production of myeloperoxidase, protease, and the reactive oxygen species, which causes oxidative stress, lipid peroxidation, and apoptosis. Protease interact with the xanthine deoxygenase in endothelial cell, forming xanthine oxidase, which inhibits the endogenous mechanism against the oxidative stress. Lipid peroxidation product form adapt with the myelin basic protein, altering its structure, triggering the lymphocytic immunological response, increasing the microglia activation and activity, causing neutropathic effect. Finally, carbon monoxide induces the cellular stress response, such as activation of hypoxia inducible factor 1 alpha, which can induce the gene regulation. This gene regulation can be protective or can result in injury depending on carbon monoxide dose and on the host factor, which remains largely unknown. NMDA denotes the N-methyl D-aspartate and the NOS neuronal nitric oxide synthesis. Now about symptoms. Symptoms of the carbon monoxide poisoning are non-specific. Mild exposure results in headache, myalgia, dizziness, and neuropsychological impairment. Severe exposure to carbon monoxide results in confusion, loss of consciousness, or death. Patient with the subclinical exposure may recognize poisoning only after an acute event or on coincidental discovery of carbon monoxide leak. In physiological amounts, the endogenous carbon monoxide function as neurotransmitter. At low level, carbon monoxide may favorably modulate inflammation, apoptosis, cell proliferation, and it upregulates mitochondrial biogenesis. As carbon monoxide exposure increases, poisoning results. So this is the spectrum of the symptom and the effect of exposure to carbon monoxide according to the level and the duration of exposure. In all humans, small amount of carbon monoxide are present and are important for multiple physiological functions, including neurotransmission. But exogenous exposure to the amount of carbon dioxide above the physiological level can result in protective or adaptive response, but exposure to even higher level result into the toxic effects. Toxic exposure can cause inflammation followed by hypoxia, although there is uncertainty regarding the range of carbon monoxide exposure above which inflammation occurs. The signs and symptoms are highly variable depending on acuity and duration of the exposure. So these include fatigue, headache, malaise, neurological impairment, confusion, anxiety, depression, then dizziness, ataxia, myocardial infarction, loss of consciousness, then convulsion, brain infarction, and sometimes death. So carbon monoxide causes the hypoxia by forming carboxyhemoglobin, shifting the oxyhemoglobin dissociation curve to the left. Carbon monoxide's affinity for hemoglobin is 200 times that of the oxygen, resulting in formation of carboxyhemoglobin with even relatively low amount of inhaled carbon monoxide. Carbon monoxide increases cytosolic heme level, leading to the oxidative stress, binding to the platelet heme protein, cytochrome C oxidase, interrupting the cellular respiration, causing production of reactive oxygen species, which in turn lead to neuronal necrosis and apoptosis. Impaired cellular respiration provokes stress response, including activation of hypoxia-inducible factor 1 alpha, resulting in neurologic and cardiac protection or injury, depending on the dose of carbon monoxide by means of G regulation. Carbon monoxide exposure also causes inflammation through multiple pathways that are independent of pathways to the hypoxia, resulting in neurological and cardiac injury. Long-term subacute exposure to the carbon monoxide lasting for more than 24 hours generally occur intermittently and may span weeks or even years. The incidence of long-term exposure is unknown. Symptoms of chronic poisoning may differ from those of acute poisoning and can include chronic fatigue, affective conditions, emotional distress, memory deficit, difficulty working, sleep disturbance, vertigo, neuropathy, paresthesias, recurrent infection, polycythemia, abdominal pain, and diarrhea. Patients commonly have neuropsychological sequelae after carbon monoxide poisoning. In one randomized trial, 46% of poison patients treated with normobaric oxygen had cognitive sequelae 6 weeks after poisoning, and 45% have had affective sequelae. Other sequelae include gait and motor disturbances, peripheral neuropathy, hearing loss, vestibular abnormalities, and dementia and psychosis, which can be permanent. Magnetic resonance imaging of the brain may reveal abnormal findings after carbon monoxide poisoning. In one prospective study of the patient with carbon monoxide poisoning, brain MRI revealed increased number of T2 weighted hyperintensities as compared with the number in normative database. Although prevalence of the imaging abnormality is unknown, other studies of carbon monoxide poisoned patients have reported basal ganglia lesion, atrophy of the hippocampus, and other structural years after poisoning, as well as abnormal results of diffusion tensor imaging month after poisoning. However, none of the abnormalities are specific to the carbon monoxide poisoning. Now about short-term management. In emergency, medical personnel are called. They should administer normobaric oxygen to the poison patient by means of non-breather reservoir face mask supplied with the high flow oxygen or 100% oxygen by means of artificial airway if appropriate. Poison patient should then transported to the emergency department for evaluation. Although the administration of normobaric oxygen hastened the elimination of carbon monoxide, one trial did not show a reduction of cognitive sequelae after inhalation of normobaric oxygen as compared to no supplemental oxygen therapy. However, since normobaric oxygen is safe, readily available, and inexpensive, it should be provided until carboxyhemoglobin level is less than 5%. Evaluation of poison patients should emphasize the adequacy of ventilation and perfusion, the neurological examination, and the exposure history. The measurement of arterial blood gases by co-oximetry provides information about adequacy of gas exchange, metabolic acidosis, and carboxyhemoglobin, and should be performed in poison patients if clinically indicated. However, measurement of venous oxyhemoglobin level is adequate for diagnostic purpose. Carboxyhemoglobin level depend on the multiple factors, including magnitude of exposure, the degree of alveolar ventilation, the blood volume, metabolic activity. But in adult male at race, the levels are determined predominantly by ambient carbon monoxide level and the duration of exposure. Carboxyhemoglobin level greater than 3% in non-smoker or greater than 10% in smoker confirms the exposure to carbon monoxide, but the level does not correlate with the presence or absence of initial symptom or with later outcome, which may be more attributable to the inflammatory aspect of poisoning than to the hypoxia. Carbon monoxide poisoning can exacerbate angina and can cause cardiac injury even in person with the normal coronaries. Therefore, poison patients should undergo cardiovascular investigation, including ECG and measurement of cardiac enzyme. If cardiac injury is present, cardiology consultation is indicated. For cases of intentional carbon monoxide poisoning, lab toxicological investigation should be performed for the detection of alcohol, benzodiazepine, narcotics, amphetamine, or other such agents. Emergency department personnel should facilitate access to the mental health resource. Now, use of hyperbaric oxygen. Healthcare provider in the emergency department should consider use of hyperbaric oxygen for treating poison patients. Hyperbaric oxygen therapy is defined as breathing of 100% oxygen by patients within hyperbaric chamber compressed to greater than 1.4 atmosphere of the absolute pressure. Hyperbaric oxygen therapy elevates the arterial and tissue oxygen tension, promoting carbon monoxide elimination, and also increases adenosine triphosphate production and reduces oxidative stress and inflammation. The incidence of cognitive sequelae was lower among patients who underwent three hyperbaric oxygen sessions. An initial session of 150 minutes, followed by two sessions of 120 minutes each, separated by interval of 6 to 12 hours. Within 24 hours after acute carbon monoxide poisoning than among patients treated with normobaric oxygen. In addition, the use of hyperbaric oxygen reduces the rate of cognitive sequelae at 12 months. In patients lacking apolipoprotein E4 allele, hyperbaric oxygen reduces the rate of cognitive sequelae at 6 months. Whereas in patients who had E4 allele, the use of hyperbaric oxygen did not reduce the rate of cognitive sequelae. Concurrent review of six trials, including two published only in the abstract form, did not support the use of hyperbaric oxygen for patients with carbon monoxide poisoning. However, the reviewed trials were heterogeneous with respect to the method used and differed in selection of patient, dosing of hyperbaric oxygen and normobaric oxygen, and long-term outcome measure. Lack of follow-up was limitation in some trials. Because the trial described above showed the significant benefit of hyperbaric oxygen, and because of the methodological limitations of the trial in which benefit was not shown, the review's conclusion have been controversial. About long-term management. Patient with the carbon monoxide poisoning should be followed medically after discharge. The extent and the rate of recovery after poisoning are variable, and recovery is often complicated by development of sequelae which can persist after exposure or develop weeks after poisoning which can be permanent. Specific therapy for sequelae after carbon monoxide poisoning is not available. Clinical experience suggests that patients with the sequelae should have their symptoms treated through cognitive, psychiatric, and vocational speech, occupational, and physical rehabilitation. Although data on the effect of these interventions in patients with carbon monoxide related sequelae are lacking. Patients with the persistent headache may benefit from evaluation by headache specialist. About prevention, governmental air quality limit for exposure to carbon monoxide are intended to keep carboxyhemoglobin level in small smoker below 3%. Carboxyhemoglobin level of 3% or more can adversely affect high-risk groups such as elderly, pregnant female, fetuses, infant, and patients with cardiovascular and respiratory disease. Accidental carbon monoxide poisoning is prevented. Carbon monoxide alarms are designed to go off at exposure level, and that would result in carboxyhemoglobin level exceeding 10%. Steps such as avoiding the operation of combustion engines indoors and performing periodic furnace inspection can prevent many cases of carbon monoxide poisoning, as can proper use of alternative heating and cooking source and generators after natural disaster. A helpful online resource for the prevention of carbon monoxide poisoning are available from the Center for Disease Control and Prevention. Thank you, guys.